Good evening, everyone. I'm Dr. Surbhi Mitra, a psychiatrist, and your host and host for this evening. Today's topic is the heme theme. So, today we would be talking mostly about iron deficiency anemia, sickle cell disease, and thalassemias. For this, we have a wonderful speaker amongst us, Dr. Dipshikha Maiti. She's trained in pediatrics from MAMC, Delhi, followed by pediatric hemat oncology from Tata Medical Center. Currently working as the head of the department, Pediatric Oncology at Institute of Child Health, Kolkata. Her areas of interest include thalassemia and childhood leukemia. Please welcome Dr. Dipshikha Maiti.
Good evening. Very glad to
Good,
be here with you today.
a very good evening, and we are very glad to have you today. So, thank you
Thank
for
you.
accepting the invitation, and let us go ahead with the session. Okay, so
Sure.
we would be starting with the absolute basics for the common people and the audience to understand. So, what are red blood cells? RBCs जिन्हें कहते हैं.
Okay, so in the human blood, we have three sorts of cells. One is the red blood cell or the RBC, जैसे आपने बोला. Besides that, we have WBC and platelets. We are concentrating mainly on the RBCs. The red blood cells are mainly concerned with carrying transport of oxygen from, say, lungs to different tissues of the body. So they contain hemoglobin, uh, which is sort of important for picking up oxygen from the human lungs, and they transport oxygen from the lungs to various tissues of the body, and then again they pick up carbon dioxide from the various tissues and bring them back to the lung from where it is sent out from the body.
Yes. Actually, my next question was going to be the same, that what is hemoglobin and how is it created? जो HB की
Right,
हम बात
it's
करते हैं and a lot of people, they read it in their test reports of CBC. तो HB क्या होता है ये लोगों को बहुत बेसिक पता है कि ये लेवल से ये लेवल तक अपना HB रहना चाहिए. That's all they know of. So would you enlighten us more about what hemoglobin is?
So, as I told you, red blood cells contain hemoglobin. Hemoglobin is a very important protein in the body, and their basic function is transportation of oxygen to the tissues of the body and then bringing back carbon dioxide from the body. Now, hemoglobin, जिसका हम लोग बात कर रहे हैं, hemoglobin contains a pigment that specifically gives the red color to the blood. Hence the name red blood cells. And जब भी हम लोग का hemoglobin drop कर रहा है, इसीलिए so then that is reflected as decrease in redness of the blood, or that is reflected as anemia in the body. So basically, hemoglobin is important to provide the red color to the blood, and the degree of hemoglobin is like you have to maintain in the appropriate level जो आप बोल रहे थे उस level में रहे, तो that is the then they can adequately carry out the functions, that is carry oxygen to the tissues so that the body can function properly. Whenever the hemoglobin is dropping, such functions will be affected, and that is reflected in various signs and symptoms, which we'll be discussing later, I think, in the course.
Yes, yes, definitely. So, what are the different types of hemoglobins that we know of?
So we have various types of hemoglobin, and it changes. Interestingly, like with the age of the child, as you grow up into an adult, the type of hemoglobin and the pattern, the percentage of each type of hemoglobin changes. So if we take an adult, we have mainly what is known as the hemoglobin A, or the adult hemoglobin. Like almost around 80 to 90% of the total hemoglobin in the body is comprised of hemoglobin A. Besides that, we also have small amounts of what is known as hemoglobin F or hemoglobin A2. It is because hemoglobin A is the major chunk of the hemoglobin. So whenever we're talking about sort of in drop in hemoglobin or anemia, it is mainly the hemoglobin A that is affected, and the various diseases that are causing anemia is related to mainly the hemoglobin A.
Okay, okay. So, as we were discussing earlier, that if the level of hemoglobin drops in the blood, so there are certain signs and symptoms that the patients experience. So, what happens when the hemoglobin drops? What are the signs and symptoms?
So basically, there are definite cutoffs for each age, and also it is dependent on the gender. Like we have sort of slightly lower cutoffs for the females as compared to the males, and it depends on the like whether the signs and symptoms will manifest will depend on the amount of drop in the hemoglobin, like how anemic you are. If it's sort of a mild anemia, there may not be any particular specific symptoms, but still you will be experiencing some sort of like interest in work. You may have increased irritability. You may be getting tired very easily. Otherwise, there might not be any manifest as such manifest signs and symptoms. As the hemoglobin keeps dropping and the anemia sort of gets from mild to moderate or becomes severe, then you one might become noticeably pale. And if the hemoglobin is too low, then the person might go into organ failures, like there may be heart failure. So that might manifest as swelling of the feet, what we call as edema. And plus there are sudden anemias which are due to destruction of the red blood cells, so that leads to jaundice also. So there may be anemia and jaundice together with that.
All right. So moving ahead, is there anything that we can do to eat? I mean, we can eat or we can do to improve the hemoglobin levels in our blood?
Okay, so if I look at hemoglobin, hemoglobin is composed of two parts. You have what is called heme that combines with the globin. Globin is basically a protein, and the heme component, that's a pigment which also encloses iron within it. So, what we need to understand is that iron forms an important part of hemoglobin. So, often we hear that there's something like if the iron is low, then we might develop anemia or what is known as iron deficiency anemia. So, always, as we advise as doctors, you do have to have a balanced diet. And specifically, there are certain food that are rich in iron, like if you are taking animal protein, eggs, meat, especially organ meats like the liver and kidney in the meat, red meat. These are rich in iron. And if you look at the vegetable sources, we have jaggery. There are dried fruits or what you call sattu. And in a common man's term, we use gur chana mungfali. Gur chana mungfali. These are all good sources of iron. So you have to take a sort of balanced amount of these diets. And also you need the other minerals also. Definitely you need to consume fruits and vegetables, a lot of water to sort of keep your hemoglobin at a proper level. Then there are certain misconceptions also, like green leafy vegetables equate with iron, or things like anar pomegranate is equated with beetroots are equated with increasing in iron in blood. But these are not quite true. In fact, things like too much of leafy vegetables like spinach or your beetroot, they contain certain chemicals like oxalate, which if taken too much would in fact stop the absorption of iron. So too much of leafy vegetables or too much of vegetables like let's say beetroot, these are not going to increase your these are not good sources of iron. I want to break the myth first. In fact, if you take too much of them, they might decrease the absorption of iron, and in fact bring down your hemoglobin level.
All right, that was a very interesting fact. Generally, people have a lot of beetroot and beetroot juices when
Correct.
they come to know that they have low
Yeah.
hemoglobin.
Yes, and anar, like anar juice is sort of equated with, right, with a drop of anar juice is equal to one drop of hemoglobin or blood, something like that. But it's not a conception. You need to take fruits, but whatever seasonal fruit is available to you at low cost, you can take any of those.
Okay, so the myth has been broken. People, please understand that all these sources that we talked about, if taken in excess, may not help in iron absorption properly and may further lead to anemia. Okay, so now that we talked about iron deficiency anemia, what is iron deficiency anemia, and is always low hemoglobin indicative of iron deficiency anemia, or it could be something else as well?
So again, like we discussed, like iron forms an important part of the hemoglobin. So If there's not enough iron available in the body is not able to synthesize enough hemoglobin, which is reflected as anemia. So yes, if you have iron deficiency, that can lead to anemia. And in fact, it is one of the commonest, rather the commonest cause of anemia in our country. Almost say two-thirds of the population is having some degree of iron deficiency anemia. But on the contrary, all anemia is not just caused by iron deficiency. There may be other underlying causes also. So, if you are really experiencing the signs and symptoms as we discussed about anemia, you need to go and see your doctor, who is going to have a good examination of you, will prescribe you some blood tests probably, and then he can come to the conclusion, right, whether this is iron deficiency anemia, or there's some other cause beyond iron deficiency anemia. In fact, iron deficiency anemia can coexist with other causes of anemia too. So in that case, you will have to treat both of them. If you just treat iron deficiency, your anemia will not be cured. So you need to see your doctor if you are thinking, or you have done a blood test on yourself and you see that your hemoglobin levels are low. You need to go to your doctor and follow his advice accordingly.
All right, all right. So thank you for the description of this. And is there anything else that you would like to add about iron deficiency anemia or talk about it, which you think is important and we missed out on it?
It's a very treatable cause. First is like we suffer a lot if we do not diagnose iron deficiency. Especially, I would say for kids, if you underdiagnose iron deficiency or you miss out on that diagnosis, the kid may have far-reaching impacts such as decrease in his IQ. He may be
Hmm.
lagging behind in his studies. There may be hyperactivity problems, which is all attributed, now it is known that it's all associated with iron deficiency. So it's a simple treatable disease. All you need to be is you need to be aware, and then very simple measures like some changes in the dietary measures. Then you have to deworm the child from time to time. I'm a pediatrician, so I'll talk more about children. And plus taking, if it is like the degree of anemia is more, you will have to take some iron supplements, which are just oral medicines. If you take them, you can easily treat this cause, and you can see a definite change in the behavior or the development of the child. The same similarly it applies also for the adult. You will find that your energy levels go up almost like right after starting iron. Your energy levels go up, you can do your work better, you can concentrate in your work better. Even might be your mood swings or the so-called depressions, those are all related to undiagnosed iron deficiency. So
Hmm.
be aware of this particular problem. It can exist. See your doctor, test yourself. If iron deficiency is there, then take the medicines or make appropriate dietary adjustment, and you will be much better. You will lead a much healthier life then.
Very true, very true. Even in psychiatry, now being a psychiatrist, I can talk about this. That when a patient has depression or anxiety, or suddenly a patient develops some sort of somatoform disorder, we definitely ask the patient to go for vitamin B12 levels and also iron levels, because we know that now it is a known fact that this causes the deficiency of these two, causes depression, causes anxiety, and also causes a lot of somatoform disorders. So once if they are corrected, the patient is treated. We don't need to prescribe antidepressants or anything, and anti-anxiety drugs, or other drugs which help in somatoform disorders, which are like atypical antidepressants, etc. We don't need to prescribe any of these once these are corrected. So yeah, thank you for the information so that I could add on to it. Okay.
Absolutely. That's a good point taken. The other one I would mention, a lot of people come in with like a lot of hair, they're having hair fall, excess of hair fall, or
Yeah,
what you call
absolutely.
alopecia. So again, a very common and treatable cause in this case is iron deficiency. You just check with the iron levels or the hemoglobin and add on a bit of iron supplements, and then you can overcome this problem also. So it has multifaceted effects, and even we don't know what other systems it is affecting. So just we need to be aware. And again, I would emphasize that check yourself for iron deficiency anemia and treat it if needed.
Yes, yes. All right, now coming to your topic of interest, that is thalassemia. So what is thalassemia?
Okay, so again, coming back to the hemoglobin. So right now we were talking about the heme part and the iron containing content in the heme that was causing problem with the synthesis of hemoglobin. Now we'll concentrate a bit on the globin part. So, globin is a protein component of the hemoglobin, and thalassemia is a disease where the synthesis of this particular globin chain, the amount of synthesis of globin chain is decreased. So, again, since you don't have the raw materials, the problem with iron deficiency was you didn't have iron. The problem with thalassemia is you don't have enough globin chains to synthesize the hemoglobin. Ultimately, the result is the same. Not enough hemoglobin is synthesized, and that is reflected as a drop in the hemoglobin, and the patient, that particular patient, is having anemia.
Correct, correct. So, who carries thalassemia and how do you inherit it?
So it's a genetic disorder,
Yeah.
and unfortunately, like Eastern India, West Bengal is endemic for thalassemia. Meaning, a lot of people, because of our inheritance, we carry the thalassemia mutant gene, the mutated gene in us. So either you can, like, there are two genes to dictate for whether you'll have a person will have a thalassemia or not. So it can be possible that both your genes are normal, and then you are an absolutely normal person. If one of your genes is mutated or causing carrying a thalassemia causing mutation, then that particular person is known as a thalassemia carrier. So what will happen with him or her is that the hemoglobin will be slightly lower as compared to the normal, but not as low that he would be requiring regular transfusions. On the other hand, if both your genes are defective or mutated, carrying thalassemia causing mutations, then the person will have what is called a thalassemia major. He will be requiring regular transfusions to keep up his hemoglobin level. So basically, thalassemia is inherited only if you're like, if one or more parents are having mutated thalassemia genes, that is, they are carriers or having the thalassemia disease, then only that particular child can have thalassemia. Two normal parents will never produce a thalassemia carrier or a major thalassemia causing children, and it is inherited in a manner what is called as the autosomal recessive, where you need to inherit two defective genes from from each, like one from the father, one from the mother, to have the major disease.
All right. So, then there are two types, right? Alpha and beta. So, what is alpha and beta thalassemia and is it the same as thalassemia major and minor?
Okay, so when we talk of the globin gene or the globin chains, there are different sort of chains there. So we have what is named as alpha chain and the beta chain. So you need of two proper alpha chains to combine with two proper beta chains to form a good hemoglobin A or the adult hemoglobin that we discussed earlier. If there is a defect in it, if there is decreased production in any of these chains, say the beta chain is not being produced in appropriate amount, then there will be not enough beta chain to combine with the alpha chain to produce enough globin. So if the beta chain is decreased in production, then we call that as beta thalassemia. If the alpha chain is not being produced enough, then we call that disease as alpha thalassemia. So these are types of thalassemia. Like in both of these, ultimately the globin chain is not being produced in enough quantity, leading to anemia. So that's one classification of thalassemia. And then you talked about thalassemia major and thalassemia minor. So that is based on your phenotype, that is based on the signs or symptoms or the manifestations of that particular patient, thalassemia carrier, or the one with major disease. If the patient has a severe thalassemia that is requiring transfusion, that is, you need to give him blood regularly to keep his hemoglobin level up, then it is called as a thalassemia major. Then there is a certain group of thalassemia, like most of the alpha thalassemias are sort of milder variety, where you need not transfuse blood regularly to keep the hemoglobin level up. That is known as a thalassemia minor, or also we have a group in between, what is called a thalassemia intermedia, where you might usually do not require regular transfusions, but might require transfusions sometimes when there are specific stressing agents, like you have a difficult infection, fever, viral infection, or you had a major surgery where you had a lot of blood loss, then you might require transfusion occasionally. We call that as a thalassemia intermediate group. So this major, minor, and intermediate group is based on the blood transfusion requirement of the patient as such, and has not got anything to do with alpha thalassemia or beta thalassemia. So some of the beta thalassemia patient can be thalassemia major, can also be thalassemia minor, depending on the transfusion requirement.
Okay, thank you for clarifying that. Okay. Now there is something known as an HBH disease also. So what is this HBH disease?
So correct, that's a type of, again, it's a type of alpha thalassemia. So
Alpha
in
thalassemia.
alpha thalassemia, we have four types of alpha thalassemia. Depending on, I told you in alpha thalassemia, the amount of alpha chain being synthesized in the body is decreased. So depending on the degree of decrease in the production, chain production, we categorize them into four types. So HBH is the disease where it is like, it's not the most severe form. We have one that is called hemoglobin but fetalis, where the alpha chain synthesis is near absent. In this case, the baby dies even before the baby can be born. Like, you will lose the fetus right in utero. The HbH form of alpha thalassemia is just a little milder as compared to the hemoglobin Bert fetalis. In this case, the alpha chain synthesis is decreased quite severely, but not as bad. It's not absent. So what happens is, like in this children, there will be anemia. There, it is usually moderate to severe anemia, which where you might require some transfusions occasionally, and usually they behave as what is known as the thalassemia intermedia, requiring transfusions at times.
Okay. So now the pertinent question after this, like typically will come that how do we diagnose thalassemia? How do we come to know that this patient has thalassemia?
So, in case of thalassemia, again, there are two forms as we discussed, the
Yeah.
thalassemia minor and the thalassemia major. So, as I told you, the thalassemia minor patients, they do not have much of clinical signs or symptoms. They wouldn't experience much of difficulty. So, they are only picked up when you test specifically for them. Like if you do a specific test for thalassemia in that particular patient, such as the HPLC, it is known as high performance liquid chromatography, then only they can pick up like they are a carrier. We often get patients like thalassemia testing is being done now usually routinely during the pregnancy period, during the first 3 months of pregnancy. Usually doctors are now prescribing the HPLC report, and sometimes patients are surprised to know that they are thalassemia carriers because they have never experienced any symptoms, they have never tested themselves, and once they test themselves, then only they can find out that they are thalassemia carriers. Then there is the group that is the thalassemia major group. They will be having, as I told you, repeated symptoms in form of anemia, and in this case, because the RBC breakdowns, there's associated jaundice, and then the abdomen gets swollen up. Your liver and spleen enlarges in size, it becomes quite big, so the abdomen gets big. Plus, usually this thalassemia is present quite early in the childhood. The child will not be growing well. He is pale. He has got a protuberant abdomen. He's not developing properly. He's not gaining in height and so on. So then you go to, again, you have to go to your doctor. You know something is wrong. They usually initially do some basic blood test, which is the complete blood count, where usually we find that the hemoglobin is low, the child has anemia. Then we prescribe a test called HPLC, which can confirm the diagnosis of thalassemia depending on the amount of hemoglobin types present in that particular patient. Plus, right now we have specific genetic tests also available to us. As we discussed, that thalassemia is caused by specific mutations inherited from the parents. So we can do specific genetic testing to pick up whether that particular mutation is involved, is present in that particular patient, and that can confirm. That is the ultimate confirmatory test for thalassemia.
Okay. Okay. So the next question obviously would be, can we prevent thalassemia? Is there any method to prevent thalassemia? knowing that it is
Yes, so
genetic.
it's correct. So it's in our hands to only we can prevent thalassemia. What we need to do is test ourselves. I told you already that Eastern India, especially West Bengal, is sort of endemic for the thalassemia. A lot of people here unknowingly are carrying the thalassemia mutant genes in them. So only when you test yourself, it is just a simple blood test called HPLC, which is available in even free of cost in some of the government hospitals as of now, also in many private centers also. If you do the HPLC test, you can know whether you are normal or you are a carrier. If you are a thalassemia carrier, you need not be worried. What you need to do is one thalassemia carrier should not be marrying another thalassemia carrier. If two of the two thalassemia carriers marry each other, then only there is a chance that their particular child will inherit one mutated gene, each from the father or the mother, and there will be what is the major thalassemia in that particular child. So we are advocating for premarital testing. Also, even case of like if it has not been done premarital, then it is, as I told you, it is being advised regularly in the pregnancy period during the first few months to find out whether the parents are both thalassemia carriers. If we see both the parents are thalassemia carriers, then the baby in utero can in fact be tested for whether he is having the major thalassemia. What we have to understand that we are more concerned with the thalassemia major patients who require regular transfusion and regular medicines, chronic medications to keep them well. The thalassemia carriers are not a problem. So even if you are a thalassemia carrier, it's not an issue. Get out of the stigma and ask all others in your family to test yourself, and try not to, like, one thalassemia carrier should not be marrying another thalassemia carrier as far as possible. Only in that way we can sort of prevent occurrence of thalassemia major in our offsprings.
Absolutely. So just jokingly adding to your point that people in endemic areas should definitely, go for premarital testing. तो लव वगैरह बाजू में रह गया, लेकिन आपने पहले डेफिनेटली थैलेसीमिया का टेस्ट कराना चाहिए. I
Yeah,
advocate I advocate this for HIV as well. HIV,
absolutely.
HBsAg.
Absolutely. You need to
Yeah,
do a, I would say, for the people who are listening in, you need to do a blood group. There are certain diseases associated with the negative blood group, certain precautions you have to take. And of course, the serology testing as HIV testing as suggested by Dr. Surbi. And thalassemia screening is a must, especially in case of endemic areas like Eastern India. Exactly. When you have a problem child in hand, लव फिर बाजू में नहीं एकदम खिड़की से बाहर चला जाएगा. If it becomes like, it becomes very difficult caring for a
yes,
child lifelong with regular transfusions, regular visits to the hospital, a lot of medicines. It's a pain for the child also, and very difficult for the parents to take care, proper care of that child. So as the old saying goes, prevention is always better than cure. So if a simple test can prevent it, then let's do it. That's what I would say.
absolutely. I even advocate this for, schizophrenia, bipolar disorder, because if in case you are already having a spouse with that disease, so caring for that spouse becomes difficult. But then in case if it's there in the child as well, then it becomes doubly it becomes infinite times difficult to take care of both of them. So I think there are a lot of things that people should consider before marrying, and they should go for testing, and there is no
Absolutely.
harm in this. Yeah.
Absolutely. And these tests are easily available. It's not a costly test. It's not very invasive. You just give some amount of blood to test it, and it can change your life basically. So, everybody who is listening in should go in for thalassemia testing, and if they haven't got it done yet.
Yes. So coming to the most major important point, that how can thalassemia be treated?
Okay. So I would again insist that prevention should be our
Is
aim.
better. Yeah.
But unfortunately, if we have a thalassemia, especially a thalassemia major child on hand, the problem with him is that he's not synthesizing enough hemoglobin in the body. So there's anemia. So the solution is like you have to regularly pump in blood from outside, from time to time. So usually they require say monthly or 2 monthly blood transfusion, specifically packed red blood cell transfusion, to keep their hemoglobin level up. If you maintain their hemoglobin level to physiological ranges, the child grows normally. Again, this is a point I want to insist. Once a thalassemic child is diagnosed, it's not an end all for him. If you properly stick to the transfusion regime, you give him blood regularly, the child is going to grow well, develop normally like any other child. They can do almost all the activities that all other children are doing, physical activities, games, sports, everything. They can do it, only that they require the blood transfusion regularly. And then certain, there you have to monitor for certain complications, plus you need to take regular medicines like vitamins, calcium, etc., as prescribed by your doctor. Then the child is going to do well. So that's one, that's a supportive management that we call. And if you really want to, like, we have even cure available for thalassemia. So what we need to understand is, like, in a normal human body, blood is synthesized in what is known as the bone marrow, the marrow inside the long bones. So it's a problem within the cells in the bone marrow that causes thalassemia. So we have an option called bone marrow transplantation available to us. So what we can do is we can replace the defective bone marrow in the body with a genetic mutation with a healthy bone marrow from certain donors, some healthy donor, and put it back in the body. So with bone marrow transplantation, a person can be completely cured of thalassemia. He will require no further transfusion. So we also have complete cures available to us, but it's a costly procedure definitely. If somebody is not able to afford transplantation, then they need to stick to the regular blood transfusion regime with regular visits to the doctor and medicines and tests as advised. You need a regular follow-up to have a healthy, relatively healthy life for the particular child.
Yes, yes. Okay. And what can be the average life expectancy of a person with severe thalassemia?
Okay, so that depends how you are managing the child. So a severe thalassemia wouldn't survive long without transfusion. If you don't transfuse, if you don't give him the required medicine, he would definitely not survive long, not beyond the first decade maybe. But on the other hand, if you are transfusing him regularly and following the medicines or advice, regular test as needed, the person can live up to adulthood and almost a near normal life as compared to any other adults. I'd like to add here, like, recently we had a patient in our hospital. She is a thalassemia, so-called thalassemia major. She has grown up to be an adult, married, and recently she delivered her own baby, a healthy baby.
Wow.
So it's that as good. So if you are transfusing the child properly, sticking to your treatment protocols, being with your doctor regularly, and then of course a transplant option is there for those who can afford it, then you can have a near normal life expectancy as compared to any other adult.
Correct. Okay. Okay. So now we are done with thalassemia. Is there something else that you would like to? Okay, we have a question by Sanjeev. Often we see low MCV and high RDW value. Ma'am, you'll have to explain these to the audience also,
Yeah.
what MCV is and what RDW, etc. is in the CBC reports. What does this indicate together? Also, if MCV value is high along with high RDW, what does that say?
Okay. So these are basically these terms you see in when you do a complete blood count. We often do a blood count for ourselves. So MCVs, RDWs, there are other terminologies like MCH or MCHC that together we call as RBC indices. So these are some measures associated with the RBC or the red blood cells. So these RBC indices help us sort of predict what is the cause of anemia in that particular child or adult, if you are seeing an adult patient. So if we take up the MCV first, MCV is mean corpuscular volume. So you are looking at the volume of RBCs. So low MCV means that the RBCs are relatively smaller as compared to normal RBCs. that is also known as microcytic. The cells are smaller, so it's micro sized as compared to normal. So if you are seeing microcytic anemia, two differential diagnoses usually come to our mind. One is iron deficiency anemia, and the second one is thalassemia. Both these diseases we are discussing at this point. So this is a very pertinent question here. So now to sort of distinguish between whether it is an iron deficiency anemia or a thalassemia, we can look at the other parameters like the RDW. The RDW is red cell distribution width. Like, what are the sizes of RBC that we are seeing in the blood slide that we have prepared? If there are various size, like you have a large RBC, you have a smaller one, if you have bizarre shaped RBCs, the RDW is going to be wide or higher. On the other hand, if you have uniformly same similar size cells, the RDW is low or normal. So you have different shape and size cell, which is called as anisocytosis and poikilocytosis, which is associated more commonly with iron deficiency anemia. So answering this question, low MCV with a high RDW usually is associated with iron deficiency anemia. On the other hand, if the MCV is low and the RDW is sort of low or normal, we are thinking of thalassemia. If the MCV, that is the volume, is high, the RBC is larger as compared to the normal RBCs, with a high RDW again, anisocytosis, poikilocytosis, then we are thinking of other vitamin deficiencies like B12 and folate, and what is called as a macrocytic or megaloblastic anemia. So these can sort of help the doctor direct what are the differential diagnosis for that particular anemia we are thinking of. And then for confirmation, we move on to the next step. If we are thinking in terms of iron deficiency, we'd like to look at the various iron levels in the blood. If you are thinking of the megaloblastic or macrocytic anemia, then we would like to do a vitamin B12 and folate assay in that particular patient to confirm this. Again, to particularly non-medicos or a patient who has done this report, I would suggest try not to interpret the reports by yourself. Please go back to your doctor and let him or her decide on the further management to be done.
Absolutely, absolutely. Okay. Okay, so now that we are done with the topic of thalassemia, would you like to, give your ending comments related to thalassemia? Would you like to add something that we probably missed in the questions?
But I think I'd again re-emphasize on the points. Let's try to prevent thalassemia. Test yourselves for by doing a HPLC. And the second one, even if somebody is in your family is having a child with thalassemia major, stick to the regular transfusion regimes and the medicines. That particular child is going to do well. So do not lose hope, even if the child is having thalassemia major, and they will do well. Don't worry about it too much.
All right. Okay, so now coming to the third and the last topic of today's session, that is sickle cell disease. So, what is sickle cell disease and how is it diagnosed?
Okay, so this is again, we have been talking about anemia, drop in hemoglobin throughout the evening. So, sickle cell disease is again a cause for anemia. So, what is happening here? Again, we'll go back to the hemoglobin. It's coming back in the discussion again and again. So, it's again a defect with the globin part of hemoglobin. Thalassemias, we saw that there was decrease in quantity of the globin chains being produced. In case of sickle cell disease, the quantity remains unaltered, but the globin chain that is being produced is defective in function. So there's problem with the quality of the globin chains being produced. So this is a group of disease that belongs to what is known as hemoglobinopathy, or diseases associated with qualitative defect in production of globin genes. So what is happening in the sickle cell disease is that again it is associated with genetic mutations. It is an inherited disorder coming from the parents to the children. The globin chain is defective due to the mutation. Here the globin chains become very sticky, so they sort of form lumps inside the RBC. The red blood cells are normally a flexible biconcave sort of shape. This changes its shape to now crescent or sickle shaped. becomes sickle shaped, and they become very sticky to each other. So what happens in these patients is that once the RBCs are trying to move through small veins or small arteries, they cannot move freely. They tend to pile up, they tend to stick to each other, these sickle shaped cells, and they tend to cause blockage of the small vessels, leading to various problems in this particular disease. So that's why this disease has been named as sickle cell disease, based on the typical appearance of the disease RBCs in patients with this particular disease.
Yes. And about the diagnosis part, how do we diagnose it?
It is again done through HPLC. So basically, again, the child will be presenting with some form of pallor along with jaundice. So usually we start with a complete blood count, looking at the hemoglobin and the RBC indices that we were talking about. So there will be some indications in the hemoglobin part. The hemoglobin will be low, and some indications in the RBC indices. Then we go in for the sort of definitive testing whether sickle cell is present or not, which can also be seen in the slides prepared from the blood. You can typically see the sickle shaped RBCs in the peripheral slides prepared from the blood of that patient. And then we go on to what we were discussing as the HPLC. The HPLC can pick up also the sickle hemoglobin, which is known as HbS. And if the sickle hemoglobin HbS is raised beyond certain point, the patient is labeled as either a sickle cell carrier or a sickle cell disease, depending on the percentage of the HbS. And plus, again, because it is a disease caused by specific genetic mutations inherited, again in autosomal recessive fashion, you have specific genetic tests available to you now. They can test for the specific mutation and let you know whether there is presence of sickle cell disease or sickle cell trait in that particular patient.
All right. Now, there is something called a sickle cell trait also. So, what is sickle cell trait?
So it is again similar to we were discussing about thalassemia minor or
Right.
thalassemia carrier. It's somewhat similar. Again, the sickle for a sickle cell disease to develop, you need two defective genes, one each inherited from the father and the mother. So if somebody is having only one defective gene, the other gene is absolutely normal. There's no mutations causing sickle cell disease, then that particular patient will be labeled as a sickle cell trait or a carrier, and he will have obviously a milder form of the disease with some bit of anemia, who may not manifest any symptom, and is only picked up when you do routinely when he is tested for a blood count or a HPLC at some point.
Okay. So, sickle cell trait is not a disease like sickle cell disease, right? So, why do
Right.
people need to get tested for sickle cell trait? What
It's
is the
again for
necessity?
similar reasons, like this is a heritable disease, as we discussed in case of thalassemia. Two carriers, like two sickle cell traits marrying each other, can produce a child with the sickle cell disease who will have all the manifestations of the disease. So you need to know whether you are a sickle cell carrier. Then you have to be careful not to marry another sickle cell trait. Then only you can prevent the major disease, the sickle cell disease occurring in your offsprings. So you need to know whether like you have there are chances in your of having sickle cell disease in your child, and to prevent that, like again we were discussing about premarital testing, doing a
Right.
HPLC. That HPLC is not only picking up thalassemia, that is also picking up sickle cell traits if it is present in you.
Correct. Correct. Absolutely correct. So, okay. So, what are the medical problems that are caused by sickle cell disease?
Okay. So, as we were discussing, the RBCs here are crescent shaped, sickle shaped. What happens? They clump together when they go into the small vessels. So, most of the signs and symptoms are because of that. They tend to block up small blood vessels, veins, and arteries. So, depending on the specific organ where it is occurring, say in the lungs, if the vessels are clogged up, they will cause what is known as painful chest crisis. So, there will be a lot of pain in the chest. There will be breathlessness. You'll be experiencing a lot of respiratory distress. Then there are small vessels on the tips of the fingers and your toes where the bloods can just get clot up and obstruct the return of the blood. Then there is pain in the tips of the finger and toes, swelling of the finger, discoloration. Those are known as what is called dactylitis. There can be small vessel blockage in the brain. and leading to what is known as stroke. A stroke, can present with various neurological deficits. There can be difficulty in movement of one limb or other. There can be a division of the facial angle of the mouth if there's sort of cranial nerve pulses. Then the if the vessels in the spleen is clogged up, then a lot of blood gets pulled in the spleen. There can be acute enlargement of the spleen, abdominal distension, a lot of pain abdomen, and so on. That's one thing. And if the spleen is like sort of permanently clogged up, the blood circulation to the spleen is cut off, the patient can lose his spleen. The spleen can just die off. So spleen is an important component that provides immunity, our body defense mechanism to the infection. So these patients become prone to various infections, specifically like influenzas, pneumonia. Sometimes it is a meningitis, brain fever, and so on. So they are immunocompromised also. Plus, these patients can have a lot of, because the RBCs tend to break down. These RBCs are defective, so they are sort of broken down in the body. That pushes up the bilirubin level in the body to cause jaundice, and they can lead to stones in the gallbladder. So these are various problems that can be associated with sickle cell disease.
All right. And what is the prevalence of this sickle cell disease?
Okay, so the prevalence varies from the particular population that we are looking at. So there are certain populations who are very sort of endemic for sickle cell disease. Belts like Gujarat, Madhya Pradesh, Chhattisgarh, even the tribal belts of West Bengal, the Purulia district, Orissa. So if you look at that particular specific groups of population, the prevalence can be as high as 40%. But again, certain population, it depends on the population you are looking at. It can be as variable between 1 to 40%. But specific ethnic groups, they have this disease very prevalent. They should be more careful. Like in our state, we would say the tribal belt, especially from the Purulia or Odisha border regions, they tend to have a lot of sickle cell diseases with as high prevalence as 40%. So they should be more careful about looking for signs and symptoms and testing for sickle cell disease.
Okay, okay, okay. So there must be some associated complications with sickle cell disease as well. So what are those associated complications that a person may suffer?
So we discussed a bit of them. Mainly, the problem
Yeah.
with sickle cell is the painful crisis that we were talking about. The
Yes.
blood vessels get clotted. So pains on the tips of finger and toes, severe pain. It's not just pain; it's severe pain requiring like injectable pain medications to bring out that pain. There can be respiratory distress. There can be lung problems. There can be a lot of serious infections that can be sort of life threatening also. And you have like the in chances of gallbladder stones are increased in these patients. They can have sorry, excuse me. So they can have
No worries.
leg ulcerations and so on. And the other specific problem that we talk about, they're more prone to stroke. There can be eye changes also. They can have retinopathy, which if left untreated can lead to blindness in that particular patient also. There are also effects in the kidney. There can be blood losses in the urine, or hematuria as we called it, that can eventually lead to kidney failures. So it almost sort of affects all organs
All
in the
the
body
organs.
if
Yeah.
left untreated. And one of the major problem is with the untreated pain symptoms in the patients. Otherwise, there are these thrombotic complications, what we call, that are mainly associated with sickle cell disease.
Okay. So what will be the life expectancy of such patients?
Okay, again, so sickle cell disease has also got good treatments in terms of medical treatment. Even transplant options, as we discussed, bone marrow transplant option is also available for sickle cell disease, which can completely cure the disease. And beyond that, also, even if are not transplanted, if you take regular medicines and you are under regular follow up of a physician with regular tests and all that, you can expect to have a near normal adult life. You can do all the activities of a normal adult. So usually in our country, the life expectancy should be around say 60 years. But for your records, like the highest age that any sickle cell patient has lived up to is 95 years, which is much beyond than anybody without any chronic diseases actually.
Mm-hmm. Okay, okay. So, coming to the most important question regarding sickle cell disease would be, what is the line of treatment of sickle cell disease, and is there any cure?
Okay, so as we were discussing here, the problem is again with the hemoglobin. There is a defective hemoglobin called the hemoglobin S, which is going up in the blood, and that is causing all the problems in the RBC and all. So we have a drug available, a medicine available to us that can sort of increase the level of other healthy hemoglobin called hemoglobin F and relatively bring down the proportion of HbS. So that particular drug is called hydroxyurea. So this has been used for a long time now, and regular use of hydroxyurea can prevent most of the big complications that we were discussing about, the strokes, the painful crisis, can be prevented by regular use of hydroxyurea in the patient. Besides that, for the patient with sickle cell disease especially, we advise them to take a lot of water. The hydration should be maintained properly in such patients, because if you get dehydrated, already their blood is sort of thick and their RBCs are sticky. So if the hydration status comes down, then the stickiness of the RBC increases and the symptoms are more precipitated in such patients. So for them, hydration is of utmost importance, especially during the summer seasons. You have to keep a tab on the hydration. Plus, again, the painful crisis can also be sort of precipitated by other stressors, like even changes in temperature to extreme cold temperature, infections like viral infections or certain high grade fever, certain drugs, anesthetics, major surgeries that can precipitate painful crisis. So in those particular situation, you have to be more careful. You have to take more care of the dehydration, avoid sudden changes in temperature to extreme heat or extreme cold temperatures. And even when you are going through surgeries, you have to take proper precautions, and you should be aware of the drugs that you are taking. You should be aware whether they will be more precipitating of the various complications of sickle cell disease. So hydroxyurea is important. Hydration is very important in these patients. Sickle cell diseases are, again, as I told you, very prone to a lot of infections. So to prevent these infections, we have to advise for some vaccines in this particular people, even in the adult. We think that vaccines are only meant for kids. So in case of sickle cell disease, because the immunity tends to be low, you have to give vaccines even into adulthood, like the vaccine against pneumonia causing pneumococcal, the brain fever causing meningococcal vaccines that need to be repeated from time to time. You have to take influenza vaccine yearly in this particular patient. And any infection, any fever has to be treated carefully. Like, you cannot sit at home. You have to go to your doctors and get the infection treated. Plus, you have to monitor for certain complications like strokes. We can predict the chances of stroke using specific ultrasound, brain ultrasounds. So if the chances are seen to be higher based on definite parameters, then you will have to start on anti-thrombotic medicines that prevent strokes in that particular patient. And in certain cases, we have to go into regular blood transfusion regime if the risk for stroke is high. And if you talk about the curative aspect, again, stem cell transplantation, bone marrow transplantation is totally curative of sickle cell disease. If one is affording and the symptoms are severe, one can go in for bone marrow transplantation and the patient can be completely cured of the disease by transplantation.
Okay, okay. So it was a wonderful session. We have come to the end of it, and thank you so much, Dr. Dipshikha, to be so brief and so precise with all your answers. I mean, I was amused with it. Like, I was asking a question, and you would simply ready with the answer and specific answers. So it was wonderful having you. Before closing, I would like to have your closing statements. Number one, I would first like to say that thank you for accepting our invitation, but we haven't covered all the blood disorders in today's session, although we did cover three major disorders. But we will continue covering more and more blood disorders. So we would like to have you again back on the show if possible. And your closing comments, please.
Absolutely my pleasure. So yeah, I think you have must have read in my introduction. I love to work with disorders in blood, specifically anemia, thalassemia. So I feel happy talking about it. And many of these diseases are preventable or easily curable. So our aim or our duty as doctors are always try to raise awareness for such diseases. And even if it
Absolutely.
helps one single person, if we can prevent one major thalassemia, one sickle cell disease from occurring, then my job would be done. So I must thank you for giving me this opportunity to reach out to people. I hope it has been helpful. If anybody is coming up with any questions, you can always forward me. I'm always available. If anybody needs any medical help also, I'll be available. And sure, I'll happy to be back anytime you want me. And have very happy to have you as a host. Very pertinent questions, simple questions that would help people, and I hope they could understand what we are talking about.
Thank you. Thank you so much.
Thank you.
Adding to your thing, yes, people, you can comment on this video because this video will be uploaded on YouTube as well as Facebook permanently, even when this live finishes. So you can comment your queries on this, and we would definitely talk to Dr. Dipshika about them, and she can cover them in the next session that we go about regarding blood disorders. So please like, comment, and share, and subscribe to our channel, that is Evrox Healthcare, so that you get to see more and more such webinars with wonderful speakers who are very intelligent, very knowledgeable, and they love spreading awareness in the society. So do join us next time as well, Saturday, 7 p.m. Particularly, we are always live, and you always get the notifications as usual. Also, at Evrox Healthcare, we care about your health and we care about your mental health as well. And I would like the admin to please kindly flash. Yeah. So, we are launching our telehealth app soon. And this is the number where you can contact us. All the mental health specialists and all the other doctors can contact us on this number, 9903641616, for the demo of this app, so that you can come on board, and we can do some teleconsultation together all over India, all over the world. And yeah, this was it about the app, and it's known as the F1 app. And yes, you will get the demo about it, so that you understand particularly how it works, and it is very simple and very user friendly. Thank you so much, and please, Dr. Dipshika, do wait for some time in the backstage after we go offline. Have a good night, people. Take care and have a wonderful Saturday night.